How often have you seen tetany or proximal muscle weakness in patients with electrolyte imbalance? Quite uncommon, no? What are the questions you would like to ask based on this history? What do you think is the cause of this abdominal discomfort and fullness? Any relevance to this?
Pardon?
What, any comments on this abdominal discomfort and fullness during the same period? What is it that you want to comment? See, there are many questions that are missing. There are a lot of questions that have not been highlighted in this presentation. So what are the questions that you'd like to ask?
Now, 45-year-old female, now she has loose stools and abdominal discomfort. Loose stools mainly, it is of...
Don't repeat. Shivraj, don't repeat it. What I want to ask you is, what are the other questions that you'd like to know from this presentation? Don't repeat it. No, this is all that we have.
Okay.
Yeah.
I want to ask any signs of malabsorption.
I do not know what are the signs of malabsorption. What do you ask?
The history suggestive, as I mentioned, ma'am, any electrolyte imbalances or calcium deficiency.
See, we'll be wasting time on this. See, if a person has loose stool, and it is for 3 months, you agree that it's a case of chronic diarrhea?
Yes, ma'am.
If it's chronic diarrhea, what are the types of chronic diarrhea? That's the way you have to take off, no?
Yes, ma'am.
So what are the types of watery diarrhea?
So I first we want to see whether it is a small bowel type of diarrhea or a large bowel type of diarrhea, or if it is watery diarrhea, whether it is fatty diarrhea or it is fatty diarrhea or
bloody diarrhea.
Bloody diarrhea. But
yeah, we don't use the term inflammatory any longer because one is morphological, the other one is pathological. So we classify it as watery. We call it as watery.
Or secretory diarrhea or osmotic diarrhea.
1 minute. Watery can be secretory or osmotic. Okay, don't confuse. Yes. Then you have a fatty diarrhea. The third one is a bloody diarrhea. So what gets excluded here? Bloody diarrhea is out.
Yes.
So now, what questions would you ask for a watery diarrhea, secretory versus osmotic?
Whether the stool used to subside after fasting or...
Exactly. Those are the questions you have to ask. Did she require hospitalization? What was the volume? Was she hospitalized? Did she get dehydrated, requiring IV fluids? Did stopping of food intake reduce its frequency? These are the questions that you'd ask. Now, fatty diarrhea is almost also excluded in this patient, no? Because it's just small volume, 30 to 50 ml each time. So therefore, if you shortlist, not a bloody diarrhea, it doesn't seem to be a fatty diarrhea. Now you're left only with a watery diarrhea. If it is a small bowel, okay? In that watery diarrhea, you have to finish off your questions regarding osmotic and take off the questions regarding the secretory diarrhea. What are the things you ask for secretory diarrhea? What are the common causes of secretory diarrhea?
Secretory diarrhea, either because of exogenous secretagogue or endogenous secretagogues, either like Vibrio cholerae or any neuroendocrine tumors, or because of any...
So secretory diarrhea will have more of an electrolyte imbalance, no? That's what it means. Okay.
Your voice.
So secretory diarrhea will have more of a electrolyte imbalance. Relating to that?
Yes.
Yeah, so that's
any
the first
history of surgery or radiotherapies in the past?
Doctor, that comes all much later. We are still here in the present history, which is missing. We do not know about whether it is related to food intake. Is there any food intolerance? Does the patient have intolerance to milk? Any intolerance to wheat? These are the questions that you have to ask as far as the small bowel diarrhea is concerned. If it is large bowel, what are the things that you should ask? Anything that's missing in the large bowel? We have no blood or mucus. That's fine. So what I would like to stress is very simple. Always the very first question that you should ask in a patient with small bowel diarrhea or any diarrhea is it painful or is it not painful? This is the first and foremost question that you should ask. If it becomes painless, you're almost excluding the inflammatory process. If it is painful, then you have the inflammatory as one inflammatory, ischemic, some of the infections. These are the ones that come in the painful diarrhea. So the very first question is, you have to ask this. So once you got which is painful or painless, then you try to find out whether it is a small bowel or large bowel. So if it's a small bowel diarrhea, watery diarrhea, then you start asking whether the patient, what we discussed, secretory versus osmotic, requiring admissions, whether the patient became dehydrated, And then, which is a 3-month history, then you ask for nutritional deficiencies. What are the nutrients? See, the history is totally incomplete. What questions would you ask? There's no point in asking glossitis, visual disturbances, and all. No? What would you ask for macronutrient? What would you ask for micronutrient? This is the way you have to approach. Are you understanding?
Yes, ma'am.
Yeah. So, what are the questions you'll ask for a macronutrient, and what are the questions you'll ask for a micronutrient deficiency?
Yes, ma'am. Macronutrient deficiency, for example, for carbohydrate malabsorption, last any history of passing excessive gas, or for
Exactly.
protein malabsorption, any history of pedal edema and all. For fatty diarrhea, we'll ask history of any offensive stool, passing history of offensive stool, and
Yeah. For fat, it's basically weight loss. Okay, it's more of a weight loss that
Yes,
is
ma'am.
significant in a fatty diarrhea. For protein loss, it will be more of an anasarca. And for
Yes.
carbohydrate, you'll have more of flatulence, abdominal bloat. So these are the ones that will tell you. So in a patient who's got a 3-month history with none of these, you are wondering what's happening to the patient. Are we dealing with a small bowel or large bowel? So there comes in your mind whether I should discuss more towards small bowel or towards large bowel. Are you understanding? So
Yes,
number one is pain. Number two is first is small bowel or large bowel. The moment you get small bowel, immediately in your mind start thinking of all the possibilities: watery, secretory, osmotic, fatty, and bloody. Bloody is out, fatty is out. We're left only with the watery diarrhea, which can be secretory or osmotic. Finish off the questions there. And then move on to the colonic symptoms that can tell you that, okay, frequency is less. It may be possible, but there's no urgency. What is the significance of urgency? We mentioned about there's no urgency in this patient. Tenesmus and urgency. What information do they?
Mainly it's of tenesmus and urgency symptoms of large bowel diarrhea, and mainly organic.
Rectum involvement. Tenesmus and urgency just tells you it's a rectal involvement. It's just a proctitis and nothing else.
Yes.
Tenesmus and urgency does not tell you it's colonic. Colonic symptoms are totally different. Tenesmus and urgency is when a person has inflammation of the rectum, then they have an urgency and tenesmus. Okay. So these are the things that you should highlight. Okay. So these are the details that you like. So therefore, when you take a history, just remember, number one, you will first take each of the chief complaints, expand on it. Once you're finished on that, then you discuss about the nutrition deficiency. See that you don't miss on the nutritional deficiency. Number three would be the WCOG performance scale, whether the patient is active or not active. And then during the same time, you say patient has remained uninvestigated or investigated. So these are the things that you have to highlight. And then before you go to the past history, just see that you've done a complete surveillance of the entire system. Can this patient have something in the CNS? Can this patient have something in the cardiovascular? Can there be something in the respiratory? So cough and fever becomes important. If the patient has fatigue, asthenia, blackouts, then we say, oh, there's iron deficiency. And then for the skeletal system, that takes out the IBD. You understand? So divide your history into chief complaints expansion. Number two would be nutritional. Do not forget the nutrition. Number three would be the WCOG performance scale. And then go for the investigations done outside or anywhere else. Give some details on that. And before going to the past history, see that you expanded on the other system evaluation. Okay, continue.
Past history, there is no history of tuberculosis, hypertension, diabetes, or dyslipidemia. Not on any regular medications. No history of abdominal surgeries.
What's the importance of regular medication?
Any drug-induced diarrhea,
such as
any PPIs or metformin.
Sartans, no? Tell me Sartan and only Sartan. What do they cause? Autoimmune entropathy.
Collagenous entropathy.
So collagenous entropathy or autoimmune entropathy. So that's a distinct entity where they have watery diarrhea. Move on.
Other history, family history. There is no history of malignancies in the family. No history of similar complaints in family. Dietary history, taking mixed diet, calorie deficit of 400 kilocalories per day and protein deficit of 20 grams. Socioeconomic status, lower middle class, modified Kuppuswamy scale of 12 and WHO performance status 0.
So now, Dr. Mahesh, any questions you'd like to ask before he summarizes? Dr. Mahesh? Okay, summarize.
Let's get a summary from him.
Yeah.
And then get the syndromic diagnosis.
Yeah. Give your summary.
45-year-old female presented with history of loose stools, 5 to 10 episodes per day since last 3 months, with no history of tenesmus, blood in stools, or urgency, and no history of any macronutrient or micronutrient deficiency, and presented with also had associated history of anorexia and weight loss since last 3 months, and no significant past or family history.
And what is it? First is the short history. No, it's a short history. So first you have to see your middle-aged lady. Short history of symptoms of small volume stool, not a small volume stool with nocturnal disturbance, in absence of abdominal pain, in absence of macro or micronutrient deficiency, but with a significant loss of weight and appetite, with no significant systemic manifestations, including extraintestinal manifestations. All these you have to highlight. Okay, you understand?
Yes.
So what is syndromic diagnosis?
It's a large volume type of diarrhea.
How is it large volume? Actually,
Large bowel type of diarrhea. Large bowel type of diarrhea with
so your syndromic diagnosis should be chronic diarrhea. No, first and foremost, it's a chronic diarrhea. You agree to that?
chronic painless large bowel type of diarrhea.
Exactly. Yeah.
Mostly functional.
Chronic small bowel diarrhea functional. Okay.
Why do you say functional?
There was no history of
then
symptoms, urgency.
No. If you got the history wrong, I think it was mentioned that initially it was not nocturnal, but later on it became nocturnal also.
Yeah,
so I don't think functional should be high up anywhere. So I think Dr. Jayanti rightly told you just now that you first, when you have a chronic diarrhea, you are right and you'll say it's a chronic diarrhea, but then you have to now differentiate whether it's a watery, fat or blood, and then decide whether it's secretory or osmotic.
Exactly.
So
exactly.
Where do you reach now? Shivraj?
Yes, sir. It's a chronic watery large bowel type of diarrhea.
You know what, Shivraj, we have to move on. So what I would say is I would put it as chronic diarrhea. And I will say my differentials would be more in favor of a colonic rather than small bowel diarrhea. But I would like to discuss few issues even in the small bowel diarrhea. And then say, so it is colonic diarrhea, and it is complicated by anorexia and weight loss with a performance scale of 0 with no significant comorbidity. So we finish that syndromic diagnosis has these 5 components. First, syndromic. Number 2, what is the possible origin of the disease? Then you finish off with the complications, comorbidity, and performance scale. And then say, I consider colonic diarrhea for the following reasons. And in that, my differentials are. So you're vouched for colonic diarrhea. If you have said functional, that's the end of your presentation. That's it. It will crash. It will be a total crash if you call this as a functional diarrhea. Do you think it's IBS? It's not IBS. Is it irritable bowel syndrome?
No.
Then why did you consider functional diarrhea at all? Now move on. Let's move on. So now tell what are your differentials. Why did you consider colonic rather than small bowel? Quickly tell within 1 or 2 minutes.
It is. I consider it as colonic because the diarrhea is of small volume, not associated with any Borborygmi signs or no history of any macro nutrient deficiency or micronutrient deficiency. So
Good.
it goes more in favor of large bowel.
Yeah. And now in that, what are your etiological causes? Possible colonic etiological causes. What are the possibilities? Differentials. Quick, you have to be quick.
Differentials would be first any infective diarrhea.
Such as?
Infective diarrhea.
Such as?
What infections? Mind you, it's a 3 months history. It's not a very long history. It's not a very short history also. So there are some certain infections which can go on for 3 months. What are those infections?
Just immediately, Shivraj, I'll tell you, once a question like this is asked, immediately classify infection, inflammation, ischemic, vascular, and neoplastic miscellaneous. Don't hesitate. Then just see
So
the
the-
infection. What should I tell? Quickly tell.
Protozoal infections,
Protozoal. Which protozoa?
amoebic infection,
Okay. Number 2.
protozoal giardiasis,
Colonic, giardiasis.
Colonic.
कहाँ यार शिवराज ऐसे don't make such mistakes. Giardia and colonic.
So what are the other infections? Tuberculosis.
Tuberculosis. Common infection. Yeah. Tuberculosis. That is no common.
What are the other infections which can go on for 3 months? Yersinia,
Yersinia.
Campylobacter.
Campylobacter jejuni.
But then again, Campylobacter is more of a jejunum than ileum.
Yeah. Ileum.
But Yersinia can cause enterocolitis.
Yeah. And then you have these rare ones, no? Gonococcal proctitis, chlamydia trachomatis. These are all the ones, but they'll have the latter 2 which I mentioned will have more of proctitis. All the rest which sir referred to can present with large bowel diarrhea. Okay. Infection will be number 1. Number 2, quick.
microscopic colitis,
Microscopic colitis, yes. But what about the weight loss and loss of appetite? Is it common?
less common.
Microscope, yeah, it's uncommon. You don't get loss of weight and loss of appetite. Any other
So
difference?
why not inflammatory other than infections?
Any
What are the
IBD?
inflammation? Inflammation other than infections, so IBD.
IBD, I would like to keep low down because there is no history of any blood in the stools.
But it can be Crohn's disease, ileocolitis, Crohn's disease.
Crohn's colitis will be a DD. Will be an important DD.
Yes.
Yeah.
Any viral infections?
Not for
Like?
3 months. CMV colitis.
Yes, ma'am.
So they will be more in immunocompromised individuals.
Yeah.
So they can happen in immunocompetent, but they can be more in immunocompromised individuals.
Yeah.
Last for 3 months.
And don't forget C. diff. Now, few differentials for small bowel diarrhea. Painless, small volume. What are the quick tell? Small bowels. Common causes.
Painless, small volume.
Bacterial overgrowth syndrome, giardiasis, strongyloidiasis, these are all the parasitic infections. Tropical flu, celiac disease, all these are small bowel pathology. They can have just small volume. The patient will have more of malabsorption, but you have to keep, they're all painless diarrheas, and you have to keep these as your differentials.
So there is a suggestion from the in the chat box about strongyloides.
Yeah, that's one. Sorry.
Okay, carry on.
Does the patient have malabsorption? No. Okay.
No.
What's the difference between mild digestion, malabsorption? These are the things that you should know. In mild digestion, the weight loss is more severe, okay, because the basic components of the products that you eat, the fat, carbohydrate, protein, they're not digested. So these are some of the vital questions, difference between maldigestion, malabsorption. And always remember this, abdominal pain is something that you should always start. Painless diarrhea versus painful diarrhea. Okay, so we just move on. So I classified it as chronic painless diarrhea, large bowel complicated by weight loss with a performance scale of 0. Small bowel diarrhea must be considered infections such as parasites, SIBO, malabsorption syndrome. This is the way I would discuss the case. Okay, so just a clue to how you should proceed with the patient. Come on, move on. Examination.
Can this be immunoproliferative small intestinal disease, IPSID?
Yes, IPSID is an important differential. Yeah, IPSID is important. Shivraj? Shivraj? Hello? On examination?
We lost contact with Shivraj, it seems.
Okay, Gajanan, please take over. Gajanan?
They are both from the same site. I think they need to reconnect themselves.
So I think we just move on.
Yes.
So on examination, this particular patient was conscious, was alert. There was a BMI of 20. blood pressure of 100/60, A febrile, pallor was present. There were no peripheral lymph nodes, no interest. And this particular PG who took the history, he mentioned no cutaneous markers of malignancy. I think that was not relevant. No, malignancy is not the issue in this patient. It is basically looking for cutaneous markers of inflammatory bowel disease. That's more important. Oral cavity examination, very important for Addison's disease, for anemia, pigmented tongue. Shivraj, you're connected?
There was some problem in connection.
Now this is a slide which has been just shown. So Shivraj, you can have a look at it.
On examination, patient conscious, alert, weight of 45 kg, BMI of 20, blood pressure 100/60 millimeters of mercury, vitals are normal, pallor present, no peripheral lymphadenopathy, interest, no cutaneous markers of malignancy, oral cavity is normal.
So oral cavity, very important, must examine. They're not looking for cutaneous markers of malignancy. That was what I was referring to. You should call it as no extraneous manifestations of inflammatory bowel disease. That's very important. All right. So on examination of the abdomen, I'll just move on. Nothing much significant. Liver is of normal size. Other signs are normal. Now, after your examination, would you like to change your diagnosis or would like to remain the same? Rectal examination was normal. Any change in your differentials? You would like to maintain as colonic versus non-colonic? Shivraj?
So Shivraj, one is that you talked about syndromic diagnosis. We discussed the syndromic diagnosis, but if somebody asks you 5 differential diagnoses in this situation, what are the 5 possibilities you'll put?
Now after this, I would like to put firstly tuberculosis first, second any bacterial infections like salmonella or
oh God, not salmonella.
3 months. 3 months.
Come on. Don't make such mistakes in the exam.
So what else? Okay, tuberculosis, we all agree.
I'm listed here.
Yes.
So the colonic, it will be colonic tuberculosis. You can consider a lymphoma. You have to consider, as sir rightly said, IBD, ulcerative colitis, Crohn's colitis, microscopic colitis, but weight loss of appetite will not be there. In small bowel, you'll consider parasitic infestation, immune deficiency state, very important, IgA deficiency, FIPSIT, ulcerative forms of tuberculosis. In patients who are immune deficient, ulcerative forms can present in this manner. And do not forget eosinophilic arthritis. That is a mucosal form. And never ever forget systemic disorders like Addison's disease presenting with diarrhea, diabetes, hypo or hyperthyroid state. Okay. This should be the approach to your patient when you're discussing. After examination, when sir asks you how to list the differences, this is how you differentiate. In any patient, including jaundice, when we discuss intrahepatic, extrahepatic, always, even if it's extrahepatic, you have to give some points for intrahepatic. That is why I've taken both colonic and I've also taken few differentials for small bowel diarrhea. Okay, we just move on. So how will you investigate this patient? So your differentials are these. These are your differentials. How will you proceed to investigate? Quick.
Okay. Firstly, routine blood investigations. Like
nothing is, Shivraj, nothing is routine, okay? We call it as baseline investigation. Nothing is routine. Nothing is routine, When you ask for an investigation, it's with the purpose. Okay. So you'll ask for a hemogram, then
hemogram, serum electrolyte levels, and stool routine and microscopy and stool examination for look for overlaps.
Tell me all the tests that you'll do in the stool examination.
Yes, ma'am. Stool, firstly, stool pH. Stool, look for microscopy for any OR parasites, and then a stool fat estimation, fecal fat estimation, and occult blood, stool for occult blood.
So what stain? Will you do any specific stains in the stool?
ZN stain for if there is any history of immunocompromised state, modified ZN stain or ZN stain to rule out any cryptosporidium, microsporiasis spora.
Yeah, it's not only immunosuppressed. In all these patients, you do not know whether they're immunosuppressed or not. So all these tests you would do. Okay. So the patient had a hemoglobin of 10.4. Anemia was present. Platelet count was 8.89. ESR was 22 and CRP was 5.7. What's your comment?
Increased leukocyte count and mainly neutrophilic leukocytosis with CRP of 5.7 and thrombocytosis.
And so it may be reactive, no? That's your comment. And the patient has got anemia.
Anemia.
Okay, next investigation. So peripheral smear showed microcytic hypochromic. Okay, neutrophilic leukocytosis and thrombocytosis. Stool examination, nothing contributory. And special AFP stain was negative for cryptosporidiasis. This we asked. Okay. So when you ask for stool examination, just remember some of these points. Gross appearance, very important. If the stool is frothy, which is giardiasis, always ask for osmolality if you're in doubt whether it's osmotic or secretory. Examine the stool fats under the microscope for the fat globule by the Sudan tree staining. Microbiology, look for giardiasis in a fresh stool specimen. Cryptosporidiasis can also be picked up. And stool calprotectin will tell you whether it's inflammatory or non-inflammatory. Okay. So when you do in liver function test, patient had hypoalbuminemia that was significant. Alkaline phosphatase was normal, gamma GT mildly elevated, blood sugar was normal, renal functions are normal, and as a routine, we screened all patients for viruses, so DNC was negative. So what will be the next investigation? So you have got the blood tests, you've got almost most of the tests is normal, serum electrolytes are normal. Stool examination is non-contributory. So what should be your next investigation of choice? You want to now make a diagnosis. What all should you do? You have a doubt whether it's small bowel or large bowel. We're not getting. In the presence of hypoalbuminemia, can you comment on this protein, albumin and globulin?
Protein is 6, albumin is 2.6 and globulin is 3.4. Hypoalbuminemia.
Just 1 minute. What is your inference when you check for albumin and globulin? If you have both albumin and globulin low, it is a protein losing state. That's the answer. Okay. If you have albumin and globulin both low, it means it's a protein losing state, suggesting which is more of an ulcerated pathology. All right. So that's the significance of that. So anyway, patient had a chest X-ray that was almost normal. Could not pick up anything because we could not. She had some little pop. She said we got the X-ray test done. What will be the next investigation of choice? What will be your next investigation?
So now you need to reach a diagnosis fast.
Fast, yeah.
What endoscope?
Lower GI endoscope.
Why not an upper GI? I said because I was still thinking for small bowel. So why should I do an upper GI? For what purpose?
I didn't get you.
Sorry?
Which of the diagnoses we discussed would be reached by upper GI endoscopy?
Celiac disease.
So what would you do? What would you do when you're doing an upper GI endoscopy in such patients?
Upper GI endoscopy, duodenal biopsy, D2 biopsy.
You take a deep, so you insert the scope deep into the D3 as close as possible to the DJ junction and take a tissue biopsy. Number one, you can even do a jejunal aspirate or a duodenal aspirate for parasites and see a fresh specimen for Giardia infection and strongyloid. So this is so it is very informative. So you will ask for a upper GI endoscopy with a duodenal biopsy.
So what if your diagnosis is Crohn's disease? Will you still take biopsies for Crohn's disease from the upper GI?
And for Crohn's disease. Where would you take a biopsy? Where would you take a biopsy if you're suspecting Crohn's disease?
Deep inside.
No, incisional biopsy for focal enhanced gastritis. All this has been discussed, no? Why did the incisional biopsy something? No, the Viva questions cannot change. Viva question just remains the same. So in Crohn's disease, you take an incisional biopsy for a focal enhanced gastritis. So the biopsy was non-specific. Okay, we didn't reach any conclusion. So what should you do next? What should you do next? Yeah, what are you looking for? Quickly tell.
Any erosions and ulcerations. Or
Shivaraj, just tell me, supposing you suspect tuberculosis, what are you looking for?
we should look at the IC valve, ma'am, and cecum and IC valve.
What else?
And we should, even if the mucosa is normal, we should take multiple biopsies to note microscopic colitis.
Yeah, normal. If it is abnormal, what do you find if it's abnormal? What will you find if it's abnormal?
You said site, ileocecal and cecum, but what are you looking for? You said ulcers.
Tuberculosis and Crohn's disease.
What type of ulcers in tuberculosis? What type of ulcers in Crohn's disease?
It will be transverse type of ulcers in tuberculosis and longitudinal ulcers in Crohn's disease. Mainly stellate type of ulcers in Crohn's disease, discrete aphthous ulcers.
These are the things that you should answer, no? This is most important. Now describe. Already the reports are here. So this particular patient had, there were some pseudopolyps. According to the person with the endoscopy, he thought there were multiple ulcers all around. And to me, it looked as though it may be circumferential, that there are no deep ulcers, no twisting ulcers. But the lesion was involving the cecum, ascending colon and transverse colon, and multiple biopsies were taken. Okay. And the specimen was also sent for histopathology and gene experts. Okay. Describe the findings. This was the histology. Describe what you see on histology. Shivraj?
So, Shivraj described the second picture and the fourth picture. They are very classical findings.
Even the first one has got classical findings.
The first one.
7 o'clock position.
A crypt abscess and crypt abscess and crypt distal.
There is a crypt, no crypt to see in any of the slides. None of the slides are showing crypt. You can see granulomas. Granulomas. Yeah. You think they're small granulomas or large granulomas?
Large granulomas.
The large granulomas, you can see Langerhans giant cells in the first one. You can see that very clear. Some of the cells are showing, some of the slides are showing clear-cut Langerhans giant cells. There are large, these are all large granulomas. So what's your inference now? So the biopsy showed architectural distortion, epithelioid granuloma, Langerhans type giant cells, and evidence of cryptitis. Ascending colon showed granulomas. Transverse colon also showed epithelioid granuloma. The pathologist gave a differential Crohn's disease versus tuberculosis. Latter favored in view of extensive granulomas and Langerhans giant cells. What should you do next? What is your next investigation? Can we start it on UTT, or you want some more investigations?
Will you do more tests on the biopsy? Will you do some more tests on the biopsy?
Something is missing, no? In this test, something is missing. What is your diagnosis? Do you think it's Crohn's or it's tuberculosis?
More of it tuberculosis rather than.
Why?
Langerhans type of giant cells with large granulomas.
What else are you looking for in a granuloma to differentiate Crohn's and tuberculosis?
Caseation granuloma, caseation necrosis.
Yeah, so the caseation was absent. The caseation was, they were all non-caseating, except that the Langerhans type giant cells favored tuberculosis. But so what should you do to know whether it's caseating or non-caseating? What would you do to know whether it's
Will you send a biopsy from something else also?
Yes.
Or you are happy with only histopathology?
The gene experts.
Exactly.
All right. All right. So how will you proceed further? Gene expert is negative.
It is a gene expert.
Yeah. What should you do next? What will be the positivity rate you expect?
Positivity rate for the tissues is less than 40%.
Why is it low?
Because
it's paucibacillary. The answer should be prompt, If you delay, then always is a delay in answering. So you should know why is it low. That is important. Okay. So what should you do now? Should we start the patient on ATT or should we start the patient on steroids and consider just Crohn's disease?
Will doing a CT scan help you in this situation? CT abdomen?
Yes, sir.
Why?
How?
To know any mesenteric thickening or any lymph nodes
What in the lymph nodes?
Mesenteric lymph nodes.
What are you looking for in lymph nodes? How will you differentiate Crohn's and tuberculosis?
It will not differentiate, but if there is any mesenteric thickening and along with that, if there is associated mesenteric lymph nodes and all, it will sometimes favor the tuberculosis rather than.
Shivraj, what in the nodes will differentiate Crohn's disease from tuberculosis?
We just discussed caseation. So, the features of caseation in the lymph nodes.
So this was the CT the patient had. So there was circumferential wall thickening in the terminal ileum, cecum, ascending colon, right two-third transverse colon, and segmental involvement of splenic. See, look at that now. There's a skip lesion, segmental involvement of splenic connection, parts of descending colon. Appendix, beautifully seen. You can see the appendix in the middle picture. Appendix is dilated, 9.5 with minimal fluid, with minimal fat strangling. Okay, and the cross section showed nodes which showed areas of necrosis. Omentum was normal, minimal free fluid in the lower abdomen and pelvis. Uterus was heterogeneous with bilateral hydrosalpinx. So, what's your diagnosis now?
Crohn's disease.
Oh God!
Huh?
Correct. Yeah.
Just now you tell that once there is necrosis in the lymph node, how can you say Crohn's as the first possibility? There is a clear-cut lymph node. You can see just in front of the kidney, which is showing necrotic material.
It's a tuberculosis. Yes, sir.
Yeah, in fact, this particular patient, this is only one which gave us a final clue that we're dealing with tuberculosis. Because until then, the pathologist kept saying it could be this. So the endoscopist was saying it was this. So then he said, okay, let's go ahead with this. What else would you do? Anything else that you would like to do? So multiple enlarged lymph nodes and paraaortic itotal region and mesentery. Okay, and there were central areas of necrosis. Anything else you would like to do to confirm the diagnosis? So incidentally, the patient, while screening for the CT abdomen, they also saw the lung slices. What is your comment on this? What is this? What is seen here?
What's posteriorly seen?
Arrow is showing something.
Is there cavity there?
Fibrocavitatory lesion.
Yes, sir.
Multiple central nodules with 3 in bud appearance and fibrocavitary lesion. 4 inch. This was not picked up on the chest X-ray. So very important that a chest X-ray can be taken. No, the lesions are very clear. Okay, so there was. So what is your diagnosis now?
Tuberculosis.
Disseminated tuberculosis involving the colon, the lung, and also the uterus, because there was heterogeneity in the. How should you treat this patient? How should you treat this patient?
Start with anti-tubercular drugs.
Yeah. Any role for MAN2? Maybe you can. The patient has been started on ATT. These are some of the questions that you need to know. What's the current regimen? 6 months versus extended treatment. You want to repeat? Do you think there could be an overlap between Crohn's and tuberculosis in this patient? Unlikely. Less likely. No? Less likely. Less likely. Okay. So these are some of the things that you'd like to know. So the take-home points are, these slides may be shared by the National Board office. So just see that you know the differences between functional and small bowel diarrhea, which you mentioned. Don't make mistakes. You must know how to differentiate small bowel and large bowel diarrhea. Dr. Mahesh, we can share the slides for the PGs, okay?
Yes, sure. We would do that.
So, and then there can always be an overlap between large bowel and small bowel diarrhea in a third of the cases. Always know the differences between secretory and malabsorptive. What is secretory? What is malabsorptive diarrhea? And this was a very nice algorithm which I presented once. And your history taking is very important. Onset, pattern, duration, stool characteristics. Always include other symptoms. Include aggravating factors. Never ever miss systemic disorders. Physical examination. See that you're not missed on the nutritional deficiency. Thyroid, very important. Go through all the systems, cardiovascular, respiratory, and the CNS. Abdomen, look for disseminated tuberculosis or any other. Always look for a mass, ascites, and tenderness. Anorectal examination is very important. And these are all the algorithmic approaches. It's a time is short. I think I'll just show these slides. And So these are some of the things that they will share the slides with you. So you can go through them, see that you don't miss any of these. Okay. And also know what are the things that you look for in osmotic gap. Okay. What is normal? When is it more than 125? When is it low? And what are the things that you look for in stool? So this is a simple diagram which I would like to concentrate on. In the small bowels, you always start with the lumen parasites, brush border enzyme deficiency. So always ask for milk intolerance or fruit intolerance. In the enterocyte, you have A beta lipoproteinemia, autoimmune enteropathy, and cryptosporidiasis, and specific transport defects. And then you move on to the next layer, that is subepithelium. You have the collagenous screw. When you come to the lamina propria, common diseases are tropical stool, celiac disease, ripples, A gamma globulinemia, CVID, and lymphangiectasia. When you come to the submucosa, you have the tuberculosis and lymphoma. And when you come down to the muscularis propria, that is muscle layer, you have amyloidosis, post-radiotherapy. And lymph nodes, including tuberculosis and lymphoma, can present with watery diarrhea and malabsorption syndrome. And what is through and through the gut? Through and through. Transmural, you have Crohn's disease, eosinophilic gastroenteritis, dysenteric ischemia, vaginal diverticulosis, and ileal resection. So these are all the conditions which are through and through. The reason why we show this is once you know that these are the causes, those will be all important no history. Okay, these are things that you say no history. Don't keep on saying too many no histories, but relevant to that particular problem, you can address the no histories. Okay. I mentioned about the systemic conditions. So learning points in this case is very important. A good history to differentiate a small and large bowel diarrhea. Questions will be asked on stool examination. Nothing is routine. You have to go for a detailed evaluation. You must know the role of diurnal biopsy in making a diagnosis of chronic diarrhea, and always have a systematic type of a workup. There's no shortcut. In this patient, you cannot start with a CT, okay? You should always start with a basic, because hemogram will give you as much information as a liver function test. Stool examination will give you as much information as a blood biochemistry. So never go through a shortcut in the exam. Supposing they ask 1 or 2 tests, they're okay. That's a different issue. But if they ask for a proper protocol of follow-up, this is the approach to this patient. Okay, Dr. Mahesh, you can...
Yeah, it's fine. I think we move on to the second presentation.
Shivraj, I hope you understood. Yeah, best wishes.
Shivraj.
Don't make many mistakes. Be very careful. Be careful when you use word functional. Do not comment on suddenly you made one diagnosis of Crohn's disease when it was favoring tuberculosis. I think you had a long question this time. One of the short notes was differentiating Crohn's and tuberculosis. No, in the exam. So see that you don't make such mistakes. All right. Okay. Case 2, Dr. Gajanan.
Yes,
Mahesh, you'll have to take this up. Okay.
Yeah, it's all right. So, Gajanan, go on reading.
A 62-year-old lady with jaundice, abdominal pain, and fever for 7 days. Pale stools, no pruritus. Symptomatic gallstone disease in 2009, had a lab coli, no comorbidities. What is your provisional diagnosis? This came to us in the outpatient clinic. What's your differential?
Cholestatic jaundice is there as there are pale stools, and since there is a history, is there any prior history to the 7 days? The prodrome is not there, so it can be an obstructive etiology as she had a past history of gallstone disease, so there can be a obstructive cause also.
So one of the possibilities, you said choledocholithiasis is one. What are the other possibilities?
The presence of abdominal pain and fever, what does it suggest?
She might be in cholangitis.
Yeah, that's what you have to say. You have to say it's probably a biliary cholangitis, no? Presence of pain. Yeah. What else can happen? When else can you get fever? If the patient has got multiple liver abscess, no?
Yes, liver abscess.
Due to cholangitis. So what you rightly said was probably extrahepatic biliary obstruction. What you should include is probably the biliary cholangitis plus minus liver abscess. That could be a complication of this. And then now tell the etiology. What are the possible causes?
So one you said CBD stone. What are the other possibilities?
What are the other possibilities?
Infective, like amoebic or hydrated liver abscess.
What? Yeah, come on.
What's the relationship? Why not biliary stricture? Will you think of a biliary stricture also?
So 2009, after 12 years, less likely.
All right, so that will be lower down.
Can it
What
be
else?
ascariasis infection?
Yes,
Ascariasis?
ascariasis can be.
Any other infections? Oriental cholangitis?
Yes, but this is the first episode, ma'am. So still a
That's
possibility.
okay.
Yes.
So what are the other possibilities? Anything related to the stone disease?
Stone disease.
Is it a complication of post-cholecystectomy? Can it be a complication? Meninges. Meninges now after cholecystectomy.
So there may be a stone in the cystic duct stump, which may cause Meniere's syndrome.
Okay. Very far-fetched. Okay. Then. So on examination, patient is oriented, febrile, heart rate is 104, patient was toxic, and liver and spleen was not palpable. She had epigastric tenderness, and cardiovascular respiratory system was normal.
Yes.
Okay, comments. Only laparoscopic scar was there. Okay.
So what next do you want? So that's a part of cholangitis, possibly.
Yes.
So what next do you want? What imaging do you want?
What
Or what investigations?
Tell me 2 investigations that will help you to make a diagnosis.
One ultrasound of the whole abdomen.
So we had these baseline. Hemoglobin was low. Total count was 20. SAP and gamma GT. SAP was 456. Gamma GT was 167. Your comment? Quick comment.
Ma'am, as the GGT and alkaline phosphatase are high, it involves that the biliary tract.
Can it be ampullary carcinoma?
Ampullary carcinoma.
Can ampullary carcinoma manifest as cholangitis? He's
Yes.
69-year-old.
Yes, ma'am, it can, but as the GGT and alkaline phosphatase is high, yes, ma'am, it is a possible. Ma'am.
Yeah, both are possible, no? Because you get it's almost a 10 times elevation, 4-fold elevation. Okay. And between ampullary and carcinoma head of pancreas, ampullary causes more of
Cholangitis is more common.
More common. And enzymes are low, no? So enzymes would always be low in extrahepatic biliary obstruction. So, do you think it's a recurrent stone or a residual stone?
Okay, ma'am.
If it is a stone, can it be a residual stone or recurrence of a CDD stone?
Yes, ma'am. If it was a, I'll first tell ma'am residual stone and recurrent. Residual stone is the stone which was already there and that is now causing obstruction. Recurrent CBD stone is that it has developed again in the CBD due to some underlying pathology like any hemolytic anemia or any this. That is
if I remember right, I think residuals is within 2 years and recurrence is beyond 2 years. I may be wrong there, but just check on that. Okay, that definition you should know. The interval between cholecystectomy and this. Okay. So ultrasound was done and post-cholecystectomy status, both there was bilobar, Ross IHBR dilatation and CPD was dilated. Next investigation.
Ultrasound. So what next?
Next.
Gajanan, what will be the next investigation?
CT scan.
So
do you want the next investigation or you want something else?
Pardon, sir?
You're happy with the CT being the next investigation?
No, sir, I would like to do a MRCP because the road track, if the biliary obstruction was there, then we can get the exact pathology.
What extra information you get with the CT?
In the CT, if there is any metastasis of the disease, then that additional information we can get.
What else? What are you seeing here? Can you comment on some of the lower parts? Go to the lowermost ones. 1, 2, 3, 4. The bottom ones. Can you see something?
Yes, ma'am. Yes, ma'am. The portal vein can be seen to be.
Portal vein?
No, high.
There's a radio opaque. There's an opaque substance there. Can you see that?
On the left, 2. The lowermost column, lowermost row. First and the second. Can you see something?
It's stone, ma'am.
Stone.
Is the shape like that of a stone?
Here, I've given you some more sections. Now tell what it is. What is your comment on the third picture on the top column, top row? And the first one is beautiful. First one. What is the finding of the first one?
That's a stent, please, ma'am.
What is it?
So they looks like a stent. You're right.
And there's a stent in the upper portion, and there's a stent
Yes.
in the CBD. So there's a broken stent there, the one on the left. So how should you manage this patient now? So what's your diagnosis now? You've seen a stent in situ, just cracks. So now what's your diagnosis?
So you have to go back to the history and find out whether they did an ERCP at the time of the previous cholecystectomy.
Yeah,
That needs to be evaluated. The only other way it can be that sometimes a surgeon, if they injure the bile duct, they may pass a stent and repair over a stent. But that is far-fetched. So more likely that the patient had a sphincterotomy and a stent placement which nobody remembered, and this stent was forgotten.
Yeah, stent was forgotten, and retrospectively, when we asked the patient, then she said yes, ERCP was done ahead
It's
of
a
the
block
polycystic.
stent.
So most
Not
probably,
only blocked, was fragmented possibly.
yeah, it must be the left segment. So it was a stage polycystic status, gross dilatation, IHB or CH in CBD, multiple abscess node in the liver, polygenitic abscess. Pancreas was normal, stent in situ, fragmented stent in left hepatic duct. How should you manage this patient? Quickly tell. You have 5 minutes left.
First, ma'am, we should start with IV antibiotics.
Just say 1, 2, 3, 4. Yeah. Next.
Stabilize the patient, IV fluids, IV antibiotics. Once patient is stable, and if it is manageable through endoscopy, ERCP stent extraction can be attempted. If not, then we should go for a surgery and remove the stent and place.
She's got now stent for 11 years. What are the problems you're likely to encounter?
And there can be fibrosis. The stent can be embedded in the wall, so it might be difficult to remove the stent by endoscopy.
Yeah, exactly.
And there may be a lot of stone material around the stent. And for the left hepatic duct stent may be more difficult. The fragment in the left hepatic duct may be more difficult. So you may have to do a cholangioscopy and try to see that and try to pull it out.
So patient was taken for an emergency after 48 hours of stabilization. And during the procedure, she did have desaturation. So a plastic stent was placed by the side of the stent. There was difficulty in complete removal. And this was the finding. So the first one shows the bulky ampulla. And you can see the stent that has been removed, by the side, the black one. And a side by side, 10, I heard it was 10 centimeter long stent that was placed by the side of this. And the plan is after 3 months or so, 3 months, not 3 weeks, sorry. The plan is to try to remove the balance of the stent, which is more, you can see that, there's a residual stent on the left side. Left side duct is still there. Okay. So, Dr. Mahesh, can you just highlight some of these important issues in this case?
I think this is an uncommon situation. But then if you land up with this, it's sometimes very difficult to remove all the fragments. Particularly, as I said, if it's gone into the hepatic ducts, it may be even more difficult because they become embedded and impacted in that area. So we would always try an endoscopic procedure, if not in one endoscopy, maybe more than one endoscopy. It's always good to do a balloon sphincteroplasty in these patients so that the passage is easier at the level of the papilla. And as I said, sometimes you may need to do a spyglass cholangioscopy to locate the stent and to pull it out with the forceps. Now we have various types of baskets which are available with the spyglass. So you can use the spyglass baskets to catch these stent fragments. But this is an uncommon problem. As you rightly said, sometimes we have to no other better option but to go for surgery, but that is the last option to do.
Yeah, in this patient, we did ask the surgeons also. So they said, we'll first try for ERCP, and if not successful, then because they can go in for biliary cirrhosis at a later stage. And the left hepatic duct, since it's blocked, they can develop this local abscess, recurrent infection. So I think there may be a role for a left hepatic resection at some stage. So these are some of the Viva questions. Name some guide wires, name common stents, differences between pancreatic and biliary stent, what would be the ideal diameter and length of the CBD stent, indications for stent deployment in symptomatic gallstone disease. Like this patient had, What would have been? Why do you think she would have had a stent deployed? That is important. Whether she had a stone then, or she had cholangitis, and so therefore they placed a stent and she went for emergency cholecystectomy. And what is the role of nasobiliary drain? When is it indicated, and what is its utility? So these are some of the questions. Any other questions, Dr. Mahesh, they should know?
No, it's great. I mean, it's perfect. I think they need to dwell on these questions, and all of them questions are important Viva questions which can be asked anywhere. So they should be prepared for this.
Yeah. So the learning points in this case is always inquire during history taking whether a symptomatic gallstone disease was complicated with jaundice and cholangitis. Always remember this. Check out whether the procedure was done. That's why I said that history, the treatment history is very important. When you come to the paragraph on treatment, you'll realize you'll ask whether any endoscopic procedure was done, was any drainage procedure was done. So automatically the history will be forthcoming. Always check if any procedure was done prior to cholecystectomy. Always inform the patient. This is the most important. Doctor's mistake. Inform the patient that there is a need for removal of a stent if placed within 3 months of deployment of the stent.
And this is a very important point which you have raised, and this can be a huge medical legal issues to the person who has done the ERCP earlier. If he has not documented in the discharge summary that this stent needs to be removed subsequently, this can be huge medical legal issues.
Yeah, because now it's life threatening. Now she's coming in a state of shock. Okay,
so with that, I think thank you very much, Dr. Jayanti. Thank you very much, Dr. Jayanti. Two very good cases.
Thank
you, Gajanan and Shivraj. We need to be more sharp, and answers must come faster than what they did today.
Yeah.
With that, we'll close the session. Dr. Jayanti, any final comment?
Nothing much. The OSCE will be like this. The last case that we discussed, we get only 5 minutes to answer that. OSCE is only for 8 minutes, I think, each case. Sometimes the short's only 5 minutes. So they just give you the pictures, is the history taken, and what's the answer. These are the questions that will be asked. So that's why I combined an OSCE with a long case. Okay. Thank you. Thank you, Dr. Mahesh.
Thank you, Dr. Jayanti. We'll come back to you after a month or so for next session with you.
We will.
Till that time, thank you very much. And Navneet, can we close down?
Thank you. Thank you, Mahesh. Thank you, Navneet.
Thank you, Dr. Jayanti.
Thank you. Thank you for the wonderful.
Navneet, are you there?